welcome to EADV Live. Today's topic, update on non-invasive for melanoma and non-melanoma skin cancer. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have a question or comments about the subject matter, send them in at any time during the presentation, and our presenter will do her best to address them at the end. Today, we are joined by our speaker, Dr. Caterina Longo. She is Associate Professor at the University of Modena and Reggio Emilia in Italy, and she is the chairman of the Residency School of Dermatology and Venereology. She is actively involved in clinical research and has published over 300 papers on topics related to skin cancer with an emphasis on melanoma, atypical nevi, Spitz-Reed nevi, and non-melanoma skin cancer. Besides skin oncology, she is interested in the application of confocal microscopy to assess the skin aging and to monitor the efficacy of skin cancer treatments. We are happy to have her with us today and happy to hand over the webcast to her. Dr. Longo.
Thank you, Christopher, for your nice presentation, and thank you all for listening to this short update on a non-invasive technique for melanoma and other skin cancer. My name is Caterina Longo, and I am working actively in the field of skin oncology since more than 10 years. And I do not have any conflict of interest to disclose for this lecture. So the main issue when we deal with skin cancer diagnosis is what should we do? What kind of tools can we use in clinical practice? That clinical practice is different from research setting. So research helps to improve clinical practice, but when we are in a busy schedule and we visit patients, especially for skin cancer, we should know what is the mainstay of tools that we can have in our hands. If we look at the literature, and we like very much guidelines worldwide developed, and we look back in the past, we see that since 2014 in US, and not only there are a list of putative candidate tools that we can use in skin cancer diagnosis. And here you see in the arrows with the square that on top of them there is dermoscopy, also named dermatoscopy, that is a tool that uses an examination that uses a dermatoscope and has a very high sensitivity and specificity for skin cancer diagnosis. And then it's followed by total body photography that usually is coupled with dermoscopy. It means that we should take a series of pictures of all skin of our patients and then check with the dermatoscope any kind of lesions, pigmented or not pigmented lesions, and confocal microscopy. So with that in mind, I was just looking through PubMed and I said, okay, let's take a look what's going on if we just Google on PubMed dermoscopy or the Boolean dermatoscopy. And as you can see here, the dermoscopy era started late in 1986, and since the beginning, we have a progressive increase in number of publications that reached more than 6,000 results. Of course, that includes everything, not only skin oncology, but also inflammatory application, infestation, parasite, inflammoscopy, and so on. But as a general idea, we got the fact that no matter of fact, dermoscopy is really something that has a great impact in our scientific community. Then I did the same for reflectance confocal microscopy, and you know, if you look at this diagram, you see that it started at least 10 years later than dermoscopy, and at the beginning in 1995, this newborn technology was started by Professor Salvador Gonzalez and Mili Radejaska from US, and they both developed the technology, but the technology was used and applied you know, by doctors, by GPs and dermatologists later on. And looking also at that schematic representation, we see that there is a progressive increase in number of publications that are more or less more than 1,000 results. So back to dermoscopy, you see here just some example of commercially available dermatoscope. And the first distinction that we should make is that we have the handheld device. So the handheld device, the one on the left, are just the fastest way to check the skin of your patient. They have the highest resolution, they are very handy, light, and you can do a fast check of the patients for every kind of condition, either for skin mole check, for inflammoscopy, or for every kind of other potential application. On the right side, there is just one example of what we call video dermatoscopy or digital dermatoscopy, because with this device, you have the possibility to visualize, to observe the dermoscopic structure of any kind of lesion, but also to record the lesion itself for subsequent monitoring. So I can just store the image and then make a comparison later on. Back to numbers, because what I'm going to give you today is just some numbers regarding, the impact of devices in clinical practice. In 2011, there was a very big study that did a 10-year multi-center survey, and as you can see from the long list of authors, this survey included worldwide centers located everywhere, and they checked whether the number needed to excise is different according to the use of dermoscopy and expertise in the field of dermoscopy. And as you can see here on the bottom line, it's incredible that in centers that were not using dermoscopy on a regular basis or with expertise, the number needed to excise is 1 out of 30 lesions. So number needed to excise, for whom of you are not familiar with this statistical, let's say, parameter, means that it's the number of lesions that you excise to find one melanoma. So it means that in non-specialized center, you excise 30 nevi to find one melanoma. What happens when we use dermoscopy? When we use dermoscopy, we had the fact, no matter of course, the expertise is influencing that, but if we look just to the use of dermoscopy with the average and expert doctors, so we see that this number, the number needed to excise, become 1 out of 8 lesions. So this has a lot of implications, because we excise less benign lesions, we find melanomas, so we find them earlier, and we have also an impact on the organization of our hospital or office out office patients. The other point is that dermoscopy was used not only in specialized referral tertiary centers, but also for GPs. So it's useful for the triage in primary care. This very recent systematic review assessed that considering all the studies reporting the accuracy in primary care, they included only 23 studies that met the inclusion criteria for this review. And overall, they were included 49,000 lesions and more than 3,000 GPs, all from high-income countries. And the conclusion of this meta-analysis or systematic review is that dermoscopy helped the triage of suspicious lesions for biopsy, urgent referral, or reassurance. Of course, it's important to have training to reach competence, and also to have an implementation of dermoscopy in primary care. But the most important things that we should underline nowadays is that dermoscopy is fundamental not only for tertiary referral center, but also for triage in primary care. Since I cannot go through all the development, all the criteria that have been recently discovered in dermoscopy to get better accuracy for skin cancer, and I have a shortage of time, I just decided to report, to describe the new dermoscopic criteria for which I was involved, and that represent something that have been developed with the aim to improve the early diagnosis of melanoma. And one of the most recent study performed on a very wide study population is this one on the accuracy of dermoscopic criteria for the diagnosis of melanoma in situ. This study, head by Emilio Lallas from Greece and myself and Geppi Argenziano and the other collaborators, included 1,285 patients in this study with a mean age that is more or less 45 years, and with a total of 1,285 lesions from these patients. The lesions that were included have 325 melanoma in situ, so a very conspicuous study population, a lot of nevi, and also other lesions, non-melanocytic, that were in differential diagnosis. So we did an evaluation of well-known criteria, but also we defined new criteria and we validated some other criteria. And as you can see here in the table 3, there are some dermoscopic indicators that discriminate melanoma in situ versus all other kind of lesions, excluding invasive melanoma. And you can see here that considering melanoma in situ versus all the other diagnoses, we have as a potent, let's say, indicator for melanoma in situ the presence of atypical network regression greater than 50%, irregular hyperpigmented areas, the presence of angulated lines, and prominent skin markings. Then I would like to underline and to show you that here with the picture, since we are talking about imaging, the criteria that I'm talking about. So in the square, the figure 2a, you see the regular hyperpigmented areas as these patchy pigmented areas located inside the lesion, inside the melanoma in situ. And you see also in B another example in which it's more easy to understand the patchy, irregular, chaotic distribution of the regular hyperpigmented areas. Of course, you know well already the blotch and the regular blotch and hyperpigmented areas, because those criteria have been described since the beginning of the dermoscopic era. And then the most potent dermoscopic indicators of melanoma in situ, if we consider melanoma in situ versus the differential diagnosis with atypical nevi, are represented by the irregular hyperpigmented areas, but also by the presence of prominent skin markings. So the criterion of prominent skin markings, as you can see in B, has been defined by our group, especially for lesions located on the limbs. And it's just the fact that you see better the skin markings that are usually present, that are usually observable on the skin, but you see better in melanoma, flat lesions located on this kind of body side, but also in a few cases also on the other body side. And then, as another interesting result, we focused our attention lately on the melanoma located on the neck. You know well that usually when we speak about body site, we all cluster together head and neck. And we speak about melanoma on the head and neck, melanoma on the head and neck, facial melanoma. But actually, there were no study before this one that was checking especially this kind of peculiar location that is the neck. As a general rule, we know that neck is usually not a frequent body site covered by nevi. Only patients with multiple nevi, only patient has nevi here, but usually it's a quite a rare finding to have nevi located on the neck. With that said, melanoma on the neck is quite, let's say, rare, because usually it's on the face and scalp, but on the neck very rarely. But we decided how to see whether there is a difference for this specific body site. The first thing that I like to highlight from a clinical point of view is that usually melanoma arising on the neck is a solitary lesion. You see here in these three examples that there are no sister lesions, let's say. There are no other lesions, pigmented lesions, besides some kind of lentigos, solar lentigos, some damaged skin. And this is the first point. The other point is that we discovered that when we look on the neck, in case you have some damaged skin on the neck, you know, patients that present poikiloderma of Sivat, some damaged skin, especially in that area, melanoma usually look like to the ones that we can observe on the face, like the facial lentigo maligna. And so this kind of melanoma shows the presence of gray color, regression, irregular hyperpigmented areas as the most frequent findings. And as you can see here, this kind of melanoma rising on the neck on some damaged skin is quite similar to lentigo maligna. On the other side, when melanoma on the neck arises on a skin that has no sun damage or very few sun damaged skin, you see that we can see more frequently the presence of irregular dots and globules and irregular pigmentation, and thus this kind of tumors is more similar to the superficial spreading melanoma subtype. Again, in that area located, you know, on this district hand and neck, we were focusing specifically on melanoma on the scalp. There are a lot of literature data that deals with the scalp, because you know well that lesions, melanoma on the scalp, sometimes has a bad prognosis, especially related to a late diagnosis. And so we were focusing our attention to detect the most early sign of melanoma in situ or thin melanomas located on the scalp. We did a study involving also other centers from Italy, but also from Australia, and we included 247 lesions, and we found interestingly that male sex, the fact of being bald, and the presence of chronic sun damaged skin were associated with all kinds of melanoma subtype, but in particular with lentigo maligna. Not surprisingly, lentigo maligna subtype were mostly located in the vertex area, especially when we have bald scalp, whereas the superficial spreading melanoma subtype is located basically in the frontal and temporal areas. If we move from clinical and epidemiological data and we move to dermoscopy world, we can tell that the dermoscopy presence of pigmented rhomboidal structures, pseudo network, obliterated hair follicles, and annular granular pattern are mostly seen in lentigo maligna melanoma type, whereas the presence of bluish and white veil is more associated with superficial spreading. And here are some examples from the paper that has been recently published on the GIDD. You can see here the bald scalp of an elderly, in which we can see clearly in dermoscopy the presence of these globules located like to form these angulated lines and rhomboidal structures. And also in confocal microscopy, we have some typical follicular tropism that is usually found in lentigo maligna. On the other hand, when we do have a superficial spreading melanoma type, as in this case, also arising next to a banal nevus, we can see that we have in dermoscopy the presence of bluish whitish veil, and we do have the presence of this kind of completely disarrangement of the epidermis on confocal microscopy. So if we move to the non-melanoma skin cancer, we cannot speak about squamous cell carcinoma because we do have a very shortage of time. I focused on basal cell carcinoma, and with this review of a couple of years ago, those authors were checking whether the diagnostic accuracy of dermoscopy for basal cell carcinoma is good enough. In this systematic review, the authors included 17 studies, And as you can see, we got excellent results because the pool sensitivity and specificity for dermoscopy for the diagnosis of BCC is 90.1% and 95% respectively, so extremely high. And interestingly, the sensitivity and specificity of dermoscopy were higher for pigmented forms compared to non-pigmented basal cell carcinoma. So actually, dermoscopy is beautiful working for basal cell diagnosis. And lately, what we have discovered is that we have a different kind of features according to aggressive forms of basal cell, and in particular, infiltrative basal cell carcinoma are mainly located on the head and neck, and they are pink lesion, plaque or papule, showing ulceration, but also a mix of vascular pattern with arborizing, but also very fine superficial telangiectasia, altogether with shiny white structures. And here are some examples. You see we have cases of infiltrating basal cell with this pinkish and whitish background and vascular pattern associated with few ulceration or no ulceration at all. And what is also interesting to note is that sometimes it is difficult, based only on dermoscopy, to assess the margins in the margins of the tumor pre-surgically. And as a new finding, because I'd like to talk about something new, some pills that you might find interesting, I like very much this paper from Christian Navarrete and colleagues from US that described the presence of multiple aggregated yellow-white globules as a clue for non-pigmented basal cell carcinoma. Those authors included more than 600 non-pigmented lesions in general, and in this kind of looking a total of 291 basal cell carcinoma, they found that 20%, more or less 20% of basal cell reveals the presence of these multiple aggregated yellow-white globules. And what is more interesting for myself, and I think for clinicians dealing with skin cancer, is that the presence of these globules, these yellow-white globules, is associated with the histologic high-risk basal cell carcinoma. And here the figures from the paper, in which you can see the yellow aggregates of those structures that can be seen both with non-polarized and polarized dermoscopy. I found interesting because it's not a common finding, but when you find them, I think that they are quite specific for infiltrative or micronodular forms of basal cell. So as the first part of this lecture, I like to summarize that dermoscopy dramatically changed the diagnostic accuracy for skin cancer diagnosis. There are several diagnostic criteria that have been established so far, and in this very short presentation, I was just highlighting the fact that all the recent efforts after 20 years of dermoscopy nowadays are directed towards the identification of new dermoscopic criteria for thin melanomas and in general to identify high-risk skin cancer. And now, moving a little bit to clinical practice, because, we are clinicians and we deal with patients every day, not only with papers. Papers come from the need that we have, the unmet need that we have in clinical practice. So the first scenario, we do have a melanoma like that. This is a doorway melanoma. Do we need anything else? I don't think so. We just need a good surgeon to cut it out, and that's it. Our diagnosis is already made based on clinical inspection. Then we have scenario number 2. Here we have a relatively young patient that come for a regular screening. If you look at that panel lesion on her arm, you don't notice anything special. There is no ugly duckling sign. You need dermoscopy. In this scenario, dermoscopy helps a lot because here we identify the irregular hyperpigmented structures inside the lesion, and this was indeed a melanoma in situ. So with dermoscopy, we are able to catch melanomas, even the ones that are not doorway melanomas, melanomas that are, let's say, inconspicuous from a clinical point of view. Then, scenario number 3. You know, a lady coming for screening, and you can see here there is a lesion located on the upper part of her arm. We have brown color, we have a patch distribution of the color. It's not clear if there is a typical network of this network. Is just, you know, the fingerprinting that we can see in solar lentigo. So what should we do in this? This is the kind of lesion that we think it's dermoscopically difficult, or at least doubtful. To solve the issue of lesions like that, the scenario number 3, we can use confocal microscopy. As I showed you before, it's now 14, 15, or 20 years that we are dealing with confocal microscopy in vivo for clinical practice, especially for skin cancer diagnosis. And here I like to show you the 2 modalities that we can have. The one that is the big one, in which we can have the possibility to check, you know, a larger field of view, and the handyscope on your right side, in which we can check difficult body site, tiny lesions. Both devices has the possibility to get black and white and grayscale images with an early histologic resolution and a laser depth penetration that is more or less 300 microns. What we can see, for me, it's still fascinating after several years working with this device. It's still fascinating to use the scope to put on the skin of the patient and to visualize clearly the cells. Here you have an example of the epidermis of a melanoma, in which you see, even if you are not familiar with the device, you see clearly the cell, you see the dendrites of the melanocytes, you see the black nucleus inside, and you can check that this is also a pleomorphic appearance of melanocytes. So with that stage, the confocal microscopy is really great to assess the epidermis, the dermoepidermal junction, and the papillary dermis. This is the limited area that we can observe, that is enough to diagnose the majority of thin melanomas as such. So looking at the literature, what is what is important to note in this study from our group published on JDV in 2014 is that the majority of melanomas have evident clinical diagnosis. There are a quote of melanomas that have dermoscopical diagnosis, but there are a tiny proportion of melanomas that can be diagnosed, that are, let's say, 9% of melanomas are below the threshold. So they are dermoscopically negative, or let's say not negative, because otherwise we will not use confocal, but they are mimicker and, lesions that can skip our surgery because they are with few criteria, let's say. To check whether confocal microscopy has an impact after years of publications of retrospective and prospective studies and development of criteria, algorithm. There are a bunch of algorithms on confocal microscopy, many also from our group, but also from Spanish group and Australasian group. And those authors decided to perform in 2017 a meta-analysis comparing dermoscopy and confocal microscopy. And they concluded that when compared with dermoscopy, confocal microscopy has a significant greater diagnostic specificity for malignant skin tumors. And here you see that in this schematic representation, this workflow, the authors at the end included only 8 studies that met the criteria to be included for this meta-analysis. And you see here the list of the studies included. And in this plot, you see that confocal microscopy has a greater specificity. You see 93.5%, so a higher sensitivity, but what is dramatically improved is the specificity. Specificity means that we get 80% in this study compared to the 52 of the ones of dermoscopy. Specificity means that we are not only good to detect more melanomas with confocal, we are better to, with confocal microscopy, to spare the unnecessary excisions of benign lesions. Later on, another Cochrane studies review were done from Cochrane Library, and you see that Cochrane is a very authoritative group performing high quality review. And in 2018, also these authors concluded that for the assessment of lesions that are difficult to diagnose using clinical and dermoscopical examination, confocal is more sensitive and specific. And here you see the curve, and what I like to underline is that the curve with confocal microscopy is much better, the ROC curve, but what is most important is that confocal helps in a narrow selected population that are the lesions that are equivocal on dermoscopy. And more recently on JDV, we performed another systematic review with Claudia Pezzini as our leading author. And we included more papers because we had more papers at that time, like 32 papers that were eligible for the study. And again, what we see is that we have a very high specificity with confocal microscopy. And more specifically, we see that we have a higher sensitivity in prospective studies and a little bit lower specificity in interventional setting. If we come back to the number needed to excise that I was talking about at the beginning regarding dermoscopy, if we just include the most, let's say, important papers made on a prospective basis, we see that accuracy for melanoma diagnosis, considering those 3 papers at least, for confocal microscopy is at the best one, the number needed to excise at the best is 1 out of 2.9 lesions. That is extremely good, is excellent, and this is basically because of the great expertise of the centers, of the Spain center performing this study. If we consider also, the first study in 2014 and the other one from our group, including 243 melanomas, so largest number of melanomas, the number needed to excise is almost the same. So it means that in the hands of experts in a very selected study population, confocal microscopy helps a lot to spare the excision of benign lesions, but also to catch as many melanomas in their early phases. But I would like to underline which is the best setting for which confocal can help. And we answered basically this question in this study from our group led by Stefania Borsari, in which we said that we had a very good number needed to excise, but the most intriguing thing is that confocal microscopy performs better in terms of diagnostic accuracy for lesions located for the face. Lentigo maligna is one of the best applications for confocal microscopy, and also all the differential diagnosis for this kind of tumors. Confocal microscopy is also useful for lesions located on subdermal skin, for which differential can be tough, but also is good for basal cell diagnosis in case of uncertainty. And further, also for diagnosing melanoma in situ in differentiated from atypical nevi. You see here 2 false lesions on dermoscopy. So one is melanoma and the other one is a nevus. And confocal microscopy in the hands of experts can help, not in all cases, but in the majority of cases. We solved the issue. So moving to recent studies, I like very much this one from Spain group, in which they checked the improvement of diagnostic confidence and management using confocal microscopy in daily practice. Because it's not only important, to check it's melanoma, is not melanoma, okay, this is the main question, but also is the important thing is to decide whether to biopsy or not, and how much I'm confident to do so. And this study actually included 272 consecutive lesions, and they said that with confocal microscopy, the lesion management changed in 33.5% of cases. So the clinician changed his mind, her mind, after using confocal. And after confocal, the number needed to excise was surprisingly 1 out of 1.2. So this was by far the most excellent result that we can have. And also, you know, in a smaller study, we decided also to check whether confocal can be used for lesions put in full digital monitoring. This study is a small one, and it's a very preliminary studies, but probably confocal can be used in lesions that show the major changes in the digital dermoscopic monitoring to increase the sensitivity. And another point in which confocal microscopy works very well is when we do have heavily pigmented lesions. We are all scared about pink tumors, and this is another interesting field of application of confocal, but also in the dark side, when we do have lesions completely black, in which we cannot always reliably define the diagnostic dermoscopic criteria, confocal microscopy is great because, you know, increase our specificity, sparing the excision of several black nevi or heavily black seborrheic keratosis, for example. So as a key points of this second part, I would like to tell you that confocal microscopy is an add-on tool to dermoscopy. It's not a standing-alone device, but can be used only in a narrow selected population, only in case in which you have dermoscopically unclear lesion. And also it's great for some specific scenarios, above all the facial lesions, in which we can use confocal also for the mapping after treatment or before surgery, and also for basal cell diagnosis. Finally, we do have another scenario in our clinical practice, that is the patient with multiple nevi. For a patient with multiple nevi, dermoscopy digital monitoring is a mainstay for clinical practice. There are a lot of papers saying that we need to monitor a lot of lesions, but a lot of lesions are anyhow excised during follow-up, and the number needed to monitor ranged from 31 to 1,000. So it's a very complex process, and now the latest development is to find a way, technology, to have a kind of semi-automatic standardization and monitoring of lesions that helps clinicians to detect the changes in a more accurate way. The point is that when we do have a patient like that, she's a very complex skin patient in which you know, sun damage is extremely prominent, and as you can see here, all the lesions of these patients are quite atypical, with regression of the typical network. In case like this, of course, we should excise all lesions that look like melanoma, but also we need to monitor a lot of them. And in these specific high-risk patients, probably the integration with confocal could be the future. There are a few studies, and this is one of the most recent one from our center, from our group, in which we try to assess the diagnostic accuracy, comparing, lesions with not only dermoscopy, but use a comparative approach also with confocal microscopy. And I think that with the implementation of technology that should be faster than the ones that we have so far with confocal, and a better integration, and probably with the artificial intelligence, we should be we should find more room for confocal microscopy in these complex, high-risk multiple nevi patients. And now, to finish, I'd like to convince you about the use of confocal and dermoscopy together for clinical practice. And here are some few examples. A lady, she came to our attention because she has a itchy papule on her cheek. She was not taking care of the onset of the lesion. She does not report any changes, nothing special. The dermatologist who consulted before us said it's a seborrheic keratosis, but the patients came saying, okay, I would like to do something because I don't like it, it's too itchy. We see in dermoscopy the presence of a media-like cyst with some vascular pattern. The lesion is quite small and there is no remarkable history. Are we sure that we can spray this lesion with cryotherapy? Well, the patient doesn't want to do surgery unless it's really needed. So confocal microscopy immediately reveals the presence of this typical melanocytic proliferation in the epidermis and also the junction with the roundish and dendritic cells altogether that for a confocalist speaks in favor of melanoma diagnosis. And indeed it was nodular melanoma, as you can see in the histology. So in lesions that are quite difficult on dermoscopy, with no remarkable history, with a pink hue, with a lot of vessels, confocal microscopy solved the issue in few seconds. Moving again into pinkish world, patients with previous basal cell carcinomas and previous cryotherapy has another new pink lesion here. The lesion reveals the presence of pink and white color altogether. There are also some scales, as you can see at 8 o'clock. Okay. Do I feel confident to spray this lesion or to do iniquimod or some photodynamic therapy? I'm not sure. When I have, lesions that do not reveal completely, they do not fulfill my checking list for BCC criteria on dermoscopy, I'd rather prefer to do confocal. And I was right, because at the first glance in the mosaic in confocal, you see the scales of face. But when looking at high magnification, I was able to identify the presence of these large pagetoid cells, also some arrangement in nests that were typically speaking in favor of melanoma, and it was early melanoma. So confocal really changed our management, saving the patient from inappropriate topical treatment. And here, young patient, you see the skin is also young, and there are some angiomas clearly identifiable, and then a papule there on the back. And this is the lesion. She would like to do laser to remove it because it's a little bit dome-shaped. What we can see here, basically pigmentation. So the main two diagnoses is dermal nevus versus basal cell carcinoma. If I use confocal, I see beautiful tumor island with palisading, and I know well that this is a basal cell carcinoma. It's a nodular type, so I know that from a management point of view, I need to do the excision. So, with this, I like to conclude my presentation with the last key points and the future direction. So, confocal and dermoscopy improves the diagnostic accuracy for skin cancer if used in appropriate setting and in the hand of expert. And to get expertise and training in confocal microscopy, if you have very few criteria in your mind and a little bit of training, you can get, let's say, you can become a beginner in 6 months. So it's not that hard, as you can see, to get expertise in confocal microscopy. And in my view, the future directions are the development of fastest, new implemented technology, and probably the implementation with artificial intelligence, and to have also teleimaging for getting a second opinion for centers in which expertise in confocal is not a mainstay. And thank you so much for your attention. And now I'm ready for your questions.
We will wait a moment while you guys, our audience, can submit your questions. If you're watching through Facebook or YouTube, right into the chat.
From the audience. Christopher, do you see any questions coming, popping up?
Right now, we don't have any questions, and we are waiting for the audience to submit them.
I cannot hear you, Kristen.
Can you hear me now?
Yes.
Okay. Let's see. We have now, if you go into the comments, we have one question. There we go.
Okay. From our colleague, what is the role for the diagnosis of desmoplastic melanoma and also the follow-up after surgery? Very interesting questions. Thank you, Dr. Sidita Borici, for this question. For desmoplastic melanoma, there are kind of a couple of reports, one from our group and the other one from others. Actually, desmoplastic melanoma is a little bit deeper located, and we need more cases to assess whether it's useful. In our case, we were able to see some spindled melanocytes within the collagen bundles, but you know, we need more studies and cases to assess whether it's useful or not. Regarding the second part of your questions, follow-up after surgery. Confocal is great to check recurrent pigmentation in a scar. So if you have a recurrent pigmentation in a scar and you might think that this is a recurrent melanoma, if you use confocal, you're able to see if it's a melanoma, recurrent melanoma or not. So it's great for that. It's also great for recurrent lentigo maligna, and it's also great to check the recurrency after treatment of basal cell carcinoma, with the exception that if the recurrent basal cell carcinoma after surgery, the recurrence is located in the deep margin, confocal microscopy unfortunately cannot assess that. If we have a recurrent basal cell after surgery that is, you know, on the epidermis and the superficial dermis, confocal is great. I hope I answered to your questions. Where would you recommend someone take a good dermoscopy course? Dear Dr. Torodova, dermoscopy course, there are many. First, I would recommend to listen to the podcasts that are freely available on the International Dermoscopy Society, because they are very short on several, there are 3 channels, 2 in English and 3 in English and also one other one in Spanish. And they are very short, but dealing with you know, melanoma diagnosis, basal cell diagnosis, and also it's easy because you are at home and you can listen to the podcast in sequence. Regarding the courses itself, we do many in Italy, but not on a regular basis. There are courses also during the ADV, the big congress at the ADV, and usually they are very well done. So it's a great opportunity for you if you can to join them. Otherwise, you can write me an email and I will let you know whether there are other going on. Nowadays, I think that all we are waiting to do courses in person after this pandemic. And thank you, Dr. Joanna Lu, for her comments saying great lecture.
Well, I think that's the end of the questions for now. And I think it would be time to wrap up. If you have anything else you'd like to say, Dr. Longo?
I'd like to thank you, Christopher, for this very nice introduction and for this organization. And I'd like also to thank the ADIVU committee, because I think that the webcasts are very nice. I was, going through the webcast done by my colleagues in the past live edition, and I think that they are useful for doctors, for students, for trained dermatologists, and I think it's a good idea to keep going with them.
And we would like to say a special thank you to you, Dr. Caterina Longo, for your engaging presentation today. and the great clinical scenarios. And on behalf of the EADV, thank you all for joining us today and sharing your thoughts and questions with us. Now, the EADV is proud to offer numerous opportunities to stay on the top of the state of the art in all things dermatology and venereology related. The EADV Honors and Awards Committee is offering scholarships consisting of complimentary registration to our Congress and a one-year EADV membership for the 2022 calendar year. Applications are due on the 15th of June, so go to www.eadvcongress2021.org. Now, the EADV is constantly offering new webcasts and podcasts. This webcast will be permanently available for EADV members on the EADV platform. Our next webcast, New Developments in the Pathogenesis and Therapy of Psoriasis, will be on the 23rd of June. And at any time, you can check out the Dermatology Podcast, EADV's official podcast, available on all major podcast platforms, including Apple and Spotify. Don't forget to follow or subscribe. Thanks again for joining us, and have a pleasant day.